Just pressing the record. Good morning, everyone. Sue Grinnell here in Petaluma today. It's a little smoky, but not like probably it is in Lake County and Mendocino. Shannon is with us from Lake and just hearing about the fires. So, and I know in Riverside, I think you've got some fires going on as well, right, Amy? So. Yeah, it's a lot. So I'm excited for this presentation today. So as part of our continued learning around the portfolio of interventions, today we're going to hear one way to approach the community clinical linkages, which is one of the 5 areas in the portfolio of interventions. What you're going to hear about today is the Pathways Community Hub model. I became aware of this during my time in Washington, and there are 9 regional ACH structures there in the state of Washington, and a lot of them are actually now beginning to use this model. So I thought it would be helpful and useful for you to hear about it. And so Rick Wilk, who is in the Chicago area, is the Director of Community Engagements with Care Coordination Systems. He assists communities in transforming delivery systems through multi-sector partnerships. He used to actually be with HRSA as a Chicago regional administrator, assisting community health coalitions, health systems, FQHCs, and profit organizations and governments leveraging their resources through those multi-sector partnerships. So he's going to share again today this Pathways Community Hub model that facilitates the inclusion of housing insecurity, homelessness, birth outcomes, re-entry services, and chronic conditions as part of the comprehensive approach to community care coordination. So with that, I'm going to turn it over to Rick.
Great. Thank you, Sue. And good morning, everyone. I hope you all are doing well. And I'm sorry to hear about the fire situation. I assume that's related to, at least to some extent, a lack of water or rain.
Yeah.
But at any rate, yeah. I'm really excited to be here with you all today. Sue and I have been talking for a number of months about sharing this comprehensive approach to community-based care coordination. But before I start out, I wanted to ask you all just a quick question. And I'm wondering, can you describe an opportunity or challenge your initiative or program has before you in just a sentence or two? And I know we have a small group, so we could go through that easily. What kind of challenge? That way I can try to address what I share toward your particular interest.
This is Larry. One of our challenges is integrating what started out as independent efforts towards the same goals. So we have organizations collaborating on parallel tracks that should be working together.
Yeah, I think we can all relate to that. Thank you for sharing, Larry. I appreciate you introducing yourself too. Would anybody else like to share?
I was, as I was thinking about this, one of the challenges that we face is we have a really good collaboration model, a collaborative model. But for some of our partners, it means that we need to be able to get our clients to them rather than them coming to the clients. And that is a significant challenge where the work is happening and where the connection to support is happening. And what collaboration actually means, what a partner will provide.
Great. And I think Pathways will get right at the heart of that. Thanks for sharing, Shannon. Anybody else?
This is Martin Love from Humboldt. We're working in substance use disorder, and one of the problems we confront is insurance and the fact that services are distributed across the insurances, and each one has a different entry point and potentially barriers.
Great, thank you. Okay, so why don't we jump into the, I wanted to share a couple things before I go into pathways. Because when Sue and I were talking, I realized you have a wide range of initiatives you're considering or implementing. And I wanted to share a few different approaches that have been growing over the country, across the country over a number of years with you. And then I'll get into the pathways. The first one is the Pathways Community Hub model, which is a comprehensive, holistic, community-based care coordination approach. There's over 50 implementations across the country serving hundreds of thousands of people, and it's a rapidly growing program. It's been funded in its creation by federal agencies and state government, and continues to be funded in operations by state government, local community government, health plans, and philosophy and philanthropy. And I'll talk a little bit much more about pathways in a moment. But a couple other models is a comprehensive community redesign to address opioid misuse. This is a program that helps all the different agencies in the community that are willing to work together to collaborate to create a coordinated approach. And that might be of interest to you, Martin. Another model is a voluntary physician model. There's over 40 implementations that have served almost 500,000 people across the country. This has been around for over 20 years. It's been steadily growing. With the advent of the Affordable Care Act and states that expanded their Medicaid, these states took some emphasis off of growing the voluntary physician model, but there's still about a third of the states that have not expanded Medicaid, and they continue to grow project access models. So, and these are targeted for uninsured individuals, and but it's an organized way for physicians to donate X number of slots to see clients over the course of the year, both primary care and specialty services. The individuals get a card, the physicians get recognition at the end of the year. So it truly is a coordinated system to provide access to physician services. And increasingly, this model is moving into the enabling services as they see the importance of the social determinants. So many of these models are now looking to expand what they do, and some are actually looking into pathways. A couple access to coverage models that might be of interest to you. One is multi-share. This is a program for people that are employed but uninsured. So if you have a job but do not have insurance, there's a program that helps employers and employees split the cost, as well as a third organization. So basically a 3-share to provide a limited type of coverage depending on what's decided in the community. This originated in Michigan and continues to exist to this day. Another example is, I'm calling it a silver access plan, but with the availability of the Obamacare plan, we still find some people do not enroll in coverage. And believe it or not, for some, it's a matter of cost and of course, the hand-holding that they get through the process, because it's not always simple to get the coverage you need. So these silver access plans provide subsidies to individuals to cover their premium, essentially. I've seen communities where hospitals donate the money to a freestanding organization, and that organization does the screening and the assistance and the provision of the subsidy. So it's an interesting program to further push people to invite people and support people in getting coverage. And of course, the hospitals like it because they have folks presenting to them that have decent insurance. The last couple examples is Clinical Quality Enhancement Program, which is a community-based affordable pharmaceutical program for the uninsured. The goal of this organization is to be in every major metropolitan area by 2020. This is not a voucher program. This is not a mail order pharmaceutical program. This is an organization that works with pharmaceutical companies to move medications to communities. The medications actually are free to the communities. They just have to pay a pretty nominal cost to pay for the administrative cost of the transaction. So essentially, the pharmaceuticals can be provided at extremely low cost to uninsured individuals. And this is increasingly including naloxone in communities. So, and then the last is a model of advanced primary and specialty care, which incorporates more detailed assessment of patients' genetic history, cancer risk assessment, medication management, and other services. So while the primary care home has been a great step in the right direction of getting comprehensive primary care for individuals, there's a wider range of services available for people, often payable through insurance. And this might, for example, the genetic or cancer risk assessment for an individual that's been diagnosed with a particular disease, their family might be interested in getting tested to see if they too are at higher risk, or an individual that's adopted or doesn't know their family lineage, they might be interested in knowing. So there's practices that are beginning to expand the types of services they provide in this area. So anyway, those are just some additional models. It struck me when I spoke with Sue that you all might be interested in those. And if you'd like to learn more, either as a group, I'd be glad to work through Sue, or individually, you have my contact information. I'd be glad to talk to you about these. So with that,
Rick,
I'm going to shift to, yes.
I just want to make sure everyone can see the slides. I got a note. Can you see slides? If you could just, Larry, you're not seeing them?
I can.
No, I don't see them. Maybe there's something wrong with my.
Shannon?
I can see the first slide, but it's not progressing through the.
Yeah, he was just speaking to those, you know, different models that are there, but he'll road through. So Larry, are you seeing it now?
I see just the first slide. That's
okay,
what I meant.
That's great.
I don't see.
Yeah, he was just speaking. And so I think, yeah. So Rick, with all of those great resources that you just shared, I think it would be amazing. I don't know if you have that written down somewhere, and because I think there was some really interesting ones that I'm not sure that I had heard of before. I think that would be really useful to have that. So I could share with the group, and so I can follow up with you after.
Yeah, that sounds good, because I just provided a quick summary. I didn't want to get into too much detail because that wasn't the focus of our conversation today, but I'd be glad to do that. Absolutely.
Yeah. Okay, great.
Yeah, I came across many of these while I was with HRSA, and they really, you know, we used to go around the country talking with communities about different models, and then they would choose sort of off the menu what they were interested in implementing.
Okay,
so
great.
That's kind of a residual of that.
Sure.
Glad
great,
to do
thank
it.
you.
Okay.
Okay.
Sure, absolutely. So let's jump into the pathways model. I'm going to keep moving because I've talked about this a little bit, but I think we're all familiar with the idea of the percentage of impact that the clinical interventions have. But of course, we have behavioral, we have the social determinants that are all huge impacts. So we're very familiar with that. I won't talk in too much detail, except to say that Pathways was designed specifically to bring all of these together in a seamless way. Next slide. If reducing risk is the work needed, because really it's about reducing risk for individuals, we do have an effective model for getting work done. The American business model is able to produce a lot and at a high level. And the question is, what are the work products of risk reduction? Because the Pathways model is based on the American business model, and that was done intentionally, and I'll talk about that a little bit later. So the two aspects is care coordination, which is to identify the risk factors and coordinate connection interventions. Well, we know at the hospital system level and at the group practice level, there's been extensive resources poured in to care coordination. But we have not seen it at the community-based level, and we have a tremendously rich range of resources at the community level. It's just they're not organized and not collaborative and not easy for the health systems to work with. So the other area is direct service. So there are interventions that are proven to address risk factors, ideally evidence-based services. So bringing these two together is what Pathways is about. So if you think about community care coordination, we know where the most at-risk individuals are, or we can find that out. Increasingly, that's easier to do. And we have the interventions that can help them. But what we need is a community delivery system that comprehensively assesses and addresses risk. So for example, just as UPS or any of the delivery companies coordinate their package delivery, why do we not at a community level coordinate the very rich range of services that are available for individuals? And this is especially important for individuals with multiple complex conditions. So here we have an example of a typical family at risk, and I'm going to do this to illustrate how Pathways kind of works on the ground. So in this instance, we have Marisol, who's pregnant, and the mother of Angelina. Marisol has lost her home, and so now she is homeless, and she and Angelina are going to move in with Miss Garcia, who has her own health challenges and lives in a one-bedroom apartment. This is a complex challenge involving 3 family members, soon to be an additional family member with multiple risk factors. Our current our current care coordination system at the community level looks something like this in most places, where you have multiple organizations who provide funding or services. Some might be to Marisol, others to Angelina, as well as Marisol or individually, and others altogether to Mrs. Garcia. This uncoordinated approach is pretty much where we're at in most places in the country. The other thing I would say is that some individuals have multiple care coordinators. We've seen individuals with up to 12 care coordinators. So if you can imagine having to deal with so many different people, it's not efficient, and I don't know how I could cope with that. The Pathways Community Hub model was designed to remove silos and fragmentation, to use existing community resources more efficiently and effectively. It focuses on common metrics to identify and track risks. Pathways is all about risk reduction. And it's a holistic community care coordination where there's one care coordinator for not just the individual, but for the entire family. Pathways pays for outcomes. It was designed to pay for measurable outcomes and for specific activities that reduce risk. It was also developed as a pay for performance system because the goal was that it would be sustainable. And increasingly, hubs are beginning to tap into that sustainability opportunity. And the last thing I'll say about the Pathways Community Hub, if the community decides to create one, is it's an independent organization owned by the community, absent of the conflicts of interest that are common in our healthcare system and drive the movement of people and how resources are provided. So what is a pathway? Here's an example. Let's just look at a housing pathway quickly. So a housing pathway, the initiation phase is when a client or family is identified to be in need of affordable housing, as is Marisol. The reasons why the housing is required are checked out. And by the way, the community health workers go out with a tablet where they enter this data. So it's almost instantaneous. The community health worker, outreach worker partners with the client to contact appropriate housing organization and schedule an appointment to meet and discuss housing options. The outreach worker also helps the client prepare for meeting with required documentation, child care, and transportation. And one thing I want to say is there's other population health initiatives out there. For example, you might have heard of Now Power, Purple Binder, and they are digital. They provide a digital inventory of resources in the community, which Pathways also does. Some of them provide referrals for clients through email, for example, or reminders. But what they don't do is the hands-on relationship building with the individual, where the care coordinator is assigned to the individual to work ongoingly, because we know how important, one, trust is for people to move ahead and do things, and two, to have the appropriate information, and three, the help to get the transportation or resolve the barriers to getting the risk-reducing services they need. So they partner with the client to do those things. The care coordinator then confirms that the client has kept the appointment with the housing organization, or if they're placed on a housing list, get information on how to contact the housing authority on a bi-weekly basis to monitor progress, and ultimately, if successful, identify this pathway as complete. So as you can see, this housing pathway and all the pathways, they really represent the community health plan. So we're familiar with having a medical record in the hospital or at the doctor's office, but how many of us have a community health plan? And that's especially important if we have complex conditions.
Rick, I just had a chat. Could you possibly go back to that slide and try and see if you can blow it up a little bit? It is a little hard to read. I thought it was just me, Shannon. I don't know. And I sent out the slides ahead of time today, so I'm not sure you'll be able to do it. So you have it, Shannon, to see.
Yeah, and I'm sorry, Sue, I cannot blow it up in this viewing mode.
Okay.
But like you say, on your slide deck that you have in advance of the meeting, you will be able to enlarge it, because you're right, it is hard to read. This is a tough one.
Yeah.
That's why I went into a little more detail than some of the other slides, so you can understand what the progression of a pathway is.
Yeah, thank you.
Sure. So Pathways is about finding, treating, and measuring. So finding is engagement of an at-risk client and collecting information through an initial checklist process. Treating them is the development of the community health plan and the signing of the pathways. And ultimately, as a closed loop referral, we need to measure. So we need to track and measure the results. And the results are generally the connections of care. Some things like pregnancy can be measured as an actual outcome. Other things you're tracking, measuring the results of the connections of care to these evidence-based services, thereby reducing risk. So for example, in the find, when you're looking to find individuals, you're looking to engage at-risk clients with checklists, and you look to see, are they at risk of being evicted, for example, relative to housing, risk of domestic violence, poor rental history, or self-imposed reason why housing might be required, for example, pets. Initial checklists are gone through depending on the individual's needs, and this is just related to housing, but there's a whole slew, a comprehensive list of questions, really. And the one thing I will say is Pathways is customizable, so if you have a particular situation, the software is easily and pretty cost-effectively revised and customized to your specific needs. That's not necessarily true with the larger medical record providers. And these checklists are used to identify the pathways to follow, which is, again, the care plan. This one may be a little hard to see, but through an assessment and initial pregnancy checklist, a pregnancy pathway was created, a postpartum pathway was created, medical home pathway, and there are other pathways created for each of the 3 individuals that we saw in the family. And again, I won't go through this in too much detail. There's an extraordinary depth to pathways, but I'm just trying to give you an overview. So another advantage of pathways is you can measure. So in the measure area, we can see community health worker A has 5 individuals that need medical homes, 2 that have pregnancy pathways, and 10 social service. These can be rolled up together for individual agencies, and you can see Agency A would have all their care coordinators with 50 medical home pathways, 25 pregnancy, and 22 social service pathways. So the advantage of this is we're rolling up common data across organizations. Now, one of the things I want to say about pathways, there's been some scientific study of the work. Pathways originated around birth outcomes and has expanded to reentry populations, opioid misuse, adult chronic conditions, a wide range of services. One of the earliest studies was done by the Maternal and Child Health Journal, and it looked at the low birth weight rate amongst those at greatest risk. And so for the control group, and this was done in Mansfield, Ohio, mostly African-American women, they had a 13% low birth weight rate, but those that enrolled in Pathways had a 6.1% rate. There was a 336% return on investment short-term, and I think about a 500% return on investment long-term in the program. So it showed really dramatic results. So once you've created a Pathways hub, it looks a little different. If you remember the fragmentation we saw before, now we have a hub in the center that works with the existing care coordination agencies. So presumably, if you're really serious about Pathways, you need care coordinators or community health workers in the community. If you don't have these in individual organizations yet, you could not implement Pathways in its entirety. Having said that, there are organizations that pick pieces of Pathways and as a starting point to move toward ultimately developing a certified Pathways community hub. But the good news is referrals go both ways, from the agency to the hub and then back, or from the agency to the hub and then to a more appropriate agency. Data is shared across agencies as appropriate and is signed off by the individual, so they would have to agree to the sharing of information. But if they want a coordinated approach, they would be willing to agree to that. So basically, there's a demographic intake. The initial checklist is completed. Pathways are assigned. Regular home visits occur using the checklist. And when pathways are completed, the individual is discharged as the pathways check is complete when there are no further issues. So essentially what we have now is one care coordinator for not just Marisol, Angelina, and Mrs. Garcia, but for all the individuals in the family. There's just one care coordinator. And these are the pathways that have been assigned for each individual. And I know I'm going through these very quickly. You can imagine you work with folks that have multiple chronic conditions. So now you can see when you have a Pathways hub working with individuals, one care coordinator with individuals, all the agencies that agree to participate in supporting the hub, and I should say, who often make up the guidance council or the governing board of the hub. So they have a stake to make sure that its autonomy is ensured and the needs of their individual organizations are addressed through the governance process, but they've created a single care coordinator for the entire family. The efficiency and the effectiveness of this approach is not comparable to the existing system. One thing I want to say, I did mention that you can start in different places. Not all communities decide to start a hub right out of the gate. Some take pieces of it, and that's absolutely, encouraged and doable. But the goal is to move toward certification. There's a national certification entity in the Rockville Institute. They work with the Pathways Community Hub Institute, which is a not-for-profit organization that develops these standards and revises them as needed. And there are a number of other organizations on that guidance council. But we've seen that organizations that are certified have been more successful in terms of their quality performance, but also in terms of sustainability, because we're seeing increasingly health plans are requiring, when hubs exist, that they be certified, again, for the quality purposes. There are 20 core pathways. I'm not going to go into them in detail, but I'm going to just stop and pick one so you can get a little sense of the nuance of the complexity. So under the social service pathway is where this pathway would be assigned if an individual is misusing opioids or has a substance use disorder. We have found that with the increase in opioid misuse, that communities that have started hubs say they need more resources. So the assessment tools are being further developed in partnership with these organizations who are on the ground providing services, as well as as well as the tools that are used by the community health workers in dealing with the clients, and tools that are shared with the organizations providing the services. So for example, the GAD-7 general anxiety disorder, or PHQ-9 to review depression in an individual. These can be shared if you're a member of Pathways. Otherwise, you have to purchase these through a separate license, each organization would. So the 20 pathways cover what individuals need and are developed further as needed. One of the things I want to point out here is, in Ohio, there are standard billing codes. So for example, if you bill for any of your services as a care coordinator, often this is done manually. That's not desirable for many organizations to be dealing with manual billings. Pathways has electronic invoicing capability. In Ohio, the health plans have agreed, so the hubs use billing codes associated with when an initial pregnancy checklist has been completed. Again, the goal is to get someone in during the first trimester. The care coordination entity gets paid, and because it's electronic invoice, it's much faster. So there's payment capability, payment mechanisms that work easier for the health plans, which make it easier for the community care coordination agencies to get paid, and get paid in a more timely manner. As a result of this, we're now seeing the development of risk reduction reports, which are live in 6 hubs in Ohio. And I'm just take a moment. There's a lot of data on this slide, but it gives you just an inkling of the power of pathways. So for example, between these 6 hubs, during a discrete period of time, 361 pathways were initiated. 109 are open to date, meaning they're still being worked. That care plan is still in process with 109 individuals. 151 have been determined to be complete, meaning the person got the service they were assigned. That's been documented that they received the service. 125 were finished incomplete. That can happen because an individual moves out of the service area, opts out of the program. Could be any number of reasons. But the median duration days to complete the social service pathway was 19 for those that were completed. The percent finished incomplete is almost 32%, and the percent completed to date is almost 43%. You may notice these numbers don't add up. There are individuals who are in process who would not show as completed or incomplete because they're still working the pathways. I want to say just one other thing about this slide. If we go down to housing, we see that for housing, it took an median duration days of 63 days to finish a pathway. 38% were finished incomplete between these 6 hubs, and almost 21% were finished complete. 38% seems fairly high, and we see communities that have it much higher, but that's not surprising because finding affordable, appropriate housing is not a simple thing to do. And so the advantage of having this kind of data of how long it takes to complete a housing pathway and how many are not complete provides you with powerful information to work with policymakers and funders to work at changing the policy and enhancing the availability of affordable housing that you might not have otherwise. Otherwise, you're competing with everyone else who's advocating for the programs. Here you have pretty detailed information of the challenges you're facing. And here we have a picture of some of the first community health workers. This is in Mansfield, Ohio. And these ladies, as you know, are assigned to individuals, and they're hired from the communities they're intended to serve. So essentially, it's a jobs program. This jobs program has a career ladder as individuals can move up to become supervisors of community health workers. They've been known to become nurses or social workers once they get in the field. So it's a jobs program as well. But these ladies are more able to identify a person at risk that might otherwise not enter the healthcare system or the social service system till far later than they should. They're also able to develop the kind of trust because they're from the neighborhood. They're more likely to get in the door of the home, to develop an ongoing relationship with the individual. And we know the value of that ongoing relationship. One is communication channels are better. Two is there's trust. And how much are you willing to share if you're misusing opioids? But if you develop a relationship with someone, you're more likely to share your challenges that you're facing. The next slide shows the progression of results in Richland County, which is where Mansfield, Ohio is. And what we see here is with the Black infant mortality rate has been steadily going down in Richland County, and it's beginning to approach the white infant mortality. As of 2017, we've actually seen that for clients enrolled in the Pathways program, the infant mortality rate is lower than that of the white population. So the implications of that is extremely powerful. So to kind of summarize, benefits of the Pathways Community Health Model is it's an evidence-based improvement in outcomes and reduction in costs. It's the highest level of pay for performance and the closest modeling to American business. And it sends training, jobs, and economic mobility to where it's needed most. A number of organizations have supported the development of Pathways, both federal organizations and state organizations, and some continue to support its development. And this next slide I saw just this year, and it's really powerful. This comes from an annual report from the Northwest Ohio Pathways Hub located in Toledo, Ohio. And we talk a lot about cross-sector partnerships and how important these are, but making them work is not a simple thing. And so as you see here, we have community organizations, we have government organizations, we have, this is a community health center, we have health plans, we have the state of Ohio, we have a wide range of organizations that are cross-sector partners in making the Northwest Ohio Pathways Hub work. And so this model gets at what I think Martin was talking about, how you can get organizations that might be providing similar or parallel services to agree to work together in a way that's more efficient and effective to meet their organization missions and obviously to improve health outcomes in the community. This next slide, which you have in your deck and we'll go through in detail, provides information if you'd like to learn more about Pathways. Of course, my contact information is here as well. And just to let you know, if you're interested in learning more, I can do that as a group through Sue or individually if you'd like to contact me. So that is the Pathways presentation. And what I was hoping to do is provide a quick video for you, just 3 minutes, just 2.5 minutes actually, that talks about how the Pathways model actually works. So I'm wondering if you can sit through for 2.5 minutes, and then I'd be glad to answer any questions. I know you've been very patient listening. And if you can bear with me while this comes up. But this video was created by an organization in Washington State. And they developed this video to help people understand how the model works. And I'm not sure why it's not coming
So
up
what
here.
you have to do is stop this share, and then you can do a new screen share. That's probably the easiest way.
Sue, can you see it? It did come up on the screen now. Is that visible
I'm
to
not
you?
seeing, all I see is the PowerPoint. Because, yeah, so
Okay.
if you, so it should say up at the top, like pause screen share or stop screen share. Yeah, there you go. So I can see it.
Is it up? Oh,
I see it.
wonderful.
Can everybody else see it? Can somebody just say
Yes.
yes?
Yeah.
Okay.
Great. Sue, you are a great coach. Thank you.
Great. Thank you.
Okay, here we go. Get your popcorn out. Can you hear that?
No. Can't hear it.
Nope, we can see it, but no sound.
All right, well then I'm just gonna, hello?
Yep.
Yeah, no sound. We can still see the video itself, but no sound.
Okay, well, we'll stop the video then. I apologize for that. I hadn't thought that would become a challenge for us. So Sue, unless you have any amazing ideas that I can implement simultaneously, I'll go to question.
Sure. Gosh darn, because that's such a great, it's such a nice little video. Did you turn up your sound all the way?
I did not.
So why don't you, because I see.
can do that.
Yeah, why don't we try that?
Can you hear that?
There we go.
Starting to.
There.
It needs to be all the way up.
All the way up. Yeah.
Okay, I'm gonna start over. Full blast.
And yeah, I will send, I'm getting asked about the link, so I'll send that to you guys.
Kathy's organization is part of the Better Health Together Pathfinder Community Hub, which makes her part of a regional network of community-based care coordinators committed to providing standardized whole-person care to people at risk. The hub receives referrals for families and individuals needing support services and pairs them with community-based coordinators like Kathy. Kathy has been helping Joe navigate and access services since he was released from jail. Because Joe will be more likely to succeed if he knows his family is also healthy and supported, Kathy will be working with his daughter Sarah and her mother Amy too. Kathy begins by going to their house to start a comprehensive risk assessment that will identify what services Amy and Sarah might benefit from. For each risk, Kathy assigns a pathway, a standard evidence-based care coordination plan designed to remove barriers to good health. Each pathway is tied to specific outcomes, and Kathy will provide support, accountability, and encouragement to Sarah and Amy to see those outcomes met and each pathway completed. Kathy learns Sarah has been missing school because of her severe asthma, which has sent her to the ER multiple times. She assigns a medical home pathway to find a regular primary care provider for Sarah, and a medication management pathway to verify that Sarah is taking her asthma medication as prescribed. Kathy assigns Amy an education pathway to present some information to her about her tobacco smoking, which might be affecting Sarah's asthma. They talk about available support to help her quit, and Kathy assigns the smoking cessation pathway. Kathy will make regular home visits to check in on Amy and Sarah's progress, and can help schedule appointments and arrange transportation. For every pathway Kathy's clients complete, such as when Sarah attends her primary care appointment or when Amy quits smoking, Kathy or her organization will receive an incentive payment rewarding her for those outcomes. In addition to her pathway, Kathy can access the Hub's up-to-date resource portal to find community connections that will support her patient's health. Because Kathy tracks every step of this process in the Pathfinder care management system, all of Amy and Sarah's providers can access and share real-time data on their clients. This data helps Better Health Together manage quality, identify gaps in service, and increase the likelihood of success for our community. The Pathfinder Community Hub gets the whole region working together for better health.
Okay, great. Well, I hope you could say that I took my earpiece and I put it over so at least there'd be a better chance you'd be able to hear it. Was it actually, could you hear any of it?
Yeah. Oh, yeah. Yeah, I could hear it. I mean, it was a little, I had my sound down, so I turned my sound up. I mean, it wasn't like perfect, but what is, right? I mean, I think it was great. And I'll send out the link so that people can have it. So, So
Great.
questions, I'd love to hear any questions that you all have. And I don't know, Rick, if you want to just do a stop screen share, or it's possible somebody might want to see some of the another slide. So could also just leave it up. So Larry, do you have a question?
Yeah, where does the money come from to pay these providers or the community organizations when they complete their pathways? Is that jointly contributed?
Yeah, we call that a braided funding stream. So, for example, some organizations already have some funding in place, whether permanent, say through the McVie, the federal home visiting program, or temporary funding. But what we're trying to do is develop sustainable funding streams that pay based on performance as well. And so there's a wide range of payers. Increasingly, health plans are paying for individual pathways or multiple pathways. Hospital systems, philanthropy will pay for individual or multiple pathways to be completed. So if, for example, your community is dealing with opioid interventions or improved birth outcomes, often philanthropy will pay for those outcomes. The health plans are able to, in Ohio, use Medicaid funding through their health plans to pay for community health workers as well. They have some discretion, some discretionary money that they can use as well. So I would call it a braided funding stream. There's actually one community in New Mexico where there's a tax levy that's been passed to support, I believe it's Albuquerque, that's supporting pathways as well. So it's a wide range, and increasing options are emerging over time.
Thanks.
Mm-hmm.
Sure.
I guess one of the questions that I have is, this is so, I mean, this is all the work that we are already doing, but what I'm catching is different, is that there is some kind of software support that is bringing all of this together. So what is the cost of that, of the physical system, so to speak?
Great. So great question. So basically, care coordination systems focuses on three primary areas: delivery system redesign, so creating a coordinated system, training community health workers in this model. So some communities have the community health workers already trained or have state certification on how they're trained, but they've not been trained in the pathways model. So training can be provided specifically for that or for a full range of comprehensive care coordination services. And so that's a separate cost. And then the third area is, you're exactly right, is the software. It's the software, the spine of the system that has allowed this extraordinary amount of data to be collected in a timely manner and in a clean manner, and be assessed and decisions made based on the assessments. In terms of cost, it depends on the size of the program. So the care coordination systems, the cost is a fraction of what you see for the population health software for Epic in organizations like these large organizations. Having said that, API or programming language is written if a hospital system is using Epic to connect CCS pathways software to that system so data can be shared, because that's often an issue. So it really depends on the number of care coordinators and number of people served, and how much of the system will be used. I mentioned earlier about the voluntary physician model. Those organizations are really looking at software around physician referrals and a small amount of social determinant referral, social service referrals. So the cost for that, that's a very limited application versus the full application. So to be able to talk about cost specifically, I have to have a conversation with you about what your organization or your community is looking to do, so we could determine what services are needed and give you, a cost estimate.
Thank you.
Sure.
Rick, one thing I'm wondering about, and I think we might have talked about this before, with all of the different pathways, is there something inside of the system that allows for, and I'm not sure if overlap or duplication, right? Where if, in the example of Marisol, or even different care coordinators, where there's coordination happening amongst those. So, you know, even though it seems like it's seamless and streamlined, I'm just wondering if you could maybe speak a little bit more to that piece.
Yeah, and that's a great point, Sue, because we almost can't believe that it exists. It's almost like when I talk to communities, sometimes I say, you know, if you had never seen a jet airliner or a plane fly and someone said, we've got this thing, and you start talking, you couldn't even imagine it. But the moment you see it, you realize, you know, some of the possibilities that a plane represents. So when to implement pathways in a community, it presumes that organization, actually, I think this was to Larry's question about organizations working independently. If they agree to work together to participate in pathways and create a hub, they're agreeing to share their data that's appropriate to share, and assuming the client signs off on it, so it's HIPAA compliant. But people do this for the benefit of comprehensive care. So that hub that we were looking at, and I don't know that I can find it quickly, becomes the coordinating point for information sharing, and that information sharing goes both ways. So these organizations are sharing information into the hub, and can go back to them from multiple organizations if they're authorized to receive it. But these folks have to agree to play. If they don't agree to play, or they don't want to participate in such a system, then they're not part of the system, and they would not have access to that. So you would have those parallel systems still in place. But if you had a critical mass of organizations participating in a coordinated manner, that's definitely progress. And ultimately, the other organizations might decide to come in and be part of the hub. So essential in this is information sharing and data sharing as appropriate to make sure that the family has all of their needs met, not individually met, which sometimes is inefficient, but also lacks the coordinative aspect that we know is necessary to get the job done right and to get people the care they need.
Rick,
does that answer your question, Sue?
Yes, yes.
Can you show us a screenshot of what the software program looks like, what a provider might see as they're trying to enter data?
I cannot. I did not get into that level of detail in this presentation. I can't even begin to tell you. The system is so complex. I would rather, if you're really interested in knowing more about that, I would have to get someone that can actually walk you through the program. But for example, I mean, just kind of on the surface, this client information sheet you see back here, we don't have much detail. Talk about, I mean, if you're talking about transportation or housing, there are questions that just keep going and going and going and going. And the advantage of this, it seems like a lot of information, but if you're going to do it and you don't do it right, why, you know, what is the benefit? And how will you know you really address an individual situation? So depending on the assessment, and the good news is that this is mostly box checking, so it's pretty quick. There is space for issues that just don't fit in the box, but what we're trying to do is create a consistency among data collection and a consistency among approaches. If there's need for customization, this software can be customized. So behind this, depending on what's determined from the pregnancy checklist and the pathway, there's a whole wide range of assessment tools and resources. So for example, the digital library of resources that Now Power or Purple Binder provide you, Pathways does that too. So you can see what resources are available in the community in a digital way. So it's a massive amount of data, and having an effective IT system is the only reason we're able to do this comprehensively. Pathways has been around about 20 years. It really didn't start to grow rapidly until the model didn't start to grow rapidly until this IT spine was created.
Mm-hmm. And right. Shannon, he shared with me a couple of videos that we opted not to show today that actually kind of you could see the screen and kind of walk through. So I'll make those available too, just so you can see it.
Okay, thank you. Because it seems like this is a specific program within the overall HMIS. As you're trying to, I mean, as communities are starting to get HMIS systems through their COCs, And what I'm hearing is that Pathways is a specific software spine within HMIS. Is that true?
Can you say that? Can you repeat that last question? It's a specific what?
Yeah, it's a specific model or software program for HMIS, the homeless management information systems that people are using in their COCs. So within a community, in order for us to get state funding for homelessness, for example, we have to have, or federal funding actually, we have to have a COC, a continuum of care. And then in order for that continuum of care to bring down monies from grants, we have to be using an HMIS. That's a homeless management information system. That's the technology that the coordinated care kind of funnels through. And what I'm hearing is that Pathways is conceptually an idea of this is how you coordinate care, but it is also an HMIS system.
I hadn't thought of it that way, but how I would answer it is this. If you have to collect certain data that's not collected through the Pathways system, the system can be customized to produce that specific data for you so that you can answer that particular funding entity, both in terms of to get paid for services, but also to report results. So it's very easily customizable and relatively cost effective or less costly to do it than what you see with the big EHR companies. So it doesn't do that specifically, but that question comes up in every single community. So when I was in La Crosse, Wisconsin last year, working with all the care coordination agencies, and this is just an interesting kind of story to share. So Mayo Clinic, Gunderson Health System, which is a huge health system in Wisconsin, came together to fund the creation of a hub and home housed by the United Way, which is an independent organization seen as not beholden to any organization. The care coordination agencies can come to the table and say, how are we going to collect our data? Do we have to collect more data? And what we say to them is, we will, through this system, customize it to collect the data that you need for your existing reporting mechanisms, but we're going to provide you additional data that would be relevant for you to help support improved outcomes and to collaborate with other organizations. So it's a value add, but there is some customization that sometimes needs to be done. So in La Crosse, they had a change. I forget what particular health area required some customization. Not all the programs did, but some of them did.
Thank you. So you'll send the video links to us then?
Yeah.
Great,
so after these web discussions, I post the slides and any materials. And then in this case, he has some videos. So we'll make that available. So because they go.
Sue, are you talking?
Go ahead.
Are you talking about the Health Bridge videos?
Yeah, the ones that you sent to me that showed kind of like the different, I don't know if it was homelessness or food. It was food, right?
Yeah.
It gave an example of going through the pathways, but you could see the screens and, kind of all of that. One thing I'm wondering, and Rick, you may or may not be able to speak to this just because of the role that you're in, because these are ACH sites that are in California and Washington is adopting it. And the slide that you showed was from Spokane, and they have 7 counties. That's their model in Washington where it's regional. Can you talk at all about the relationship between kind of the ACH, the hub, and are they serving as a hub? Because I know they've all moved to 501c3s, like they're nonprofits. Do you have a sense of that in Washington, just because of the ACH?
Yeah, I don't have it for all the regions, but I do know that some are actually hosting and have become hubs.
Yeah.
So some have, yes. Yeah, I don't think in all cases, but in some cases they actually have, because again, they're an independent organization, and that's critical to Pathways. We need to remove the conflict of interest in the referral process if we're really going to get people the services they need and control the costs better. So in Washington State, I think it's 2/3 of those regions are implementing or have implemented hubs. Some are early stage, but they're very committed to doing it in the state. Yeah.
I know Tacoma is as well, and Spokane, but I'm just kind of curious because I think that's something for you all as you're thinking about the role that you play as an ACH and that hub, however it is that you go about it. It sounds like Shannon, you're doing some of this, but maybe hopefully this isn't offensive cobbling it together, because there's not like a structural place like something like this, but it's just something to consider in your role, right? So great. Any other questions from the group? Well, great. Oh, and then this was another, I don't know if you want to speak to that.
Well, that was just, again, this is just where we started out. When I initially spoke with Sue and she was explaining to me some of what you're doing or thinking about doing, and I did a little more background research to see what your accountable communities for health are doing. I realized that there's a lot of different models you might want to consider. And Sue, connected to me through care coordination systems to talk about pathways specifically. So that explains the focus on this. But through my work at HRSA, I've had the chance to work with a lot of different models and know the leaders of these programs around the country and what they're doing. And so if any of these are of interest to you as well, I'd be glad to get you information about them and help you consider the opportunities that they present. So really, I just want to say, I think Pathways is, when I left HRSA, of all the things I wanted to do, I wanted to work with community-based care coordination, because I think it's one of the missing legs on the stool to our healthcare system and bringing coordination. I would never thought of that, except as a project officer, I had the chance to work with Drs. Mark and Sarah Redding, who really formulated the notion of Pathways through their work in Alaska, where they started as physicians thinking they could save the world, and they realized that the community health workers were really running the show, particularly in these very remote areas. And it really changed the way they thought about healthcare and moved from a clinical to a public health kind of thinking. And they evolved that over the years till they ended up in Mansfield. But there are other approaches, and your community may be interested in doing multiple things. So, for example, the pharmaceutical program here, that is very complementary to Pathways, because you can identify a need for pharmaceuticals, but you can't find a way to get a person services. So the organization that runs this program is very collaborative and has worked with Pathways hubs to, parallel to create the capacity to provide pharmaceuticals, so that when that's identified as a need for an individual, they actually have affordable access. So anyway, glad to talk to you about any or all of these if they're of interest to you. And I want to thank you for inviting me to talk with you about this. This is truly, as you can guess, Pathways is my passion, and any chance I have to share it with people, I'm always appreciative.
Great. Thank you so much. Thanks, everybody. Have a good day.
Thank you.
Bye-bye.
Bye.
Bye.